This video will demonstrate the three-layer decompression of the middle cranial fossa for the treatment of cavernous sinus meningiomas. The patient is a 38-year-old female presenting with left side vision loss, third coronary palsy, and V1 hyperesthesia. Left side orbital fissure and anterior clinoid hyperostosis was seen in the CAT scan, along with a cavernous sinus extraaxial lesion extending from the orbit towards the tentorial and Meckel scape. Considering the tumor size and the progressive worsening of patient symptoms, it was recommended to undergo surgical resection of the meningioma, cavernous sinus decompression through a MiniPretemporal approach. The patient is positioned supine with the head slightly hyperextended and rotated 15 degrees. This position will allow the temporal lobe to fall during the intradural dissection without the need of using retractors. The key surgical steps of this approach include the interfacial dissection of the temporalis muscle, the extradural pretemporal minipterional approach, and a three-layer decompression, including bone, dura, and intradural space. A linear incision of about 6 inches, extended from the mid-pupillary line to 1 cm above the tragus, is performed. After skin retraction, interfacial dissection of the temporalis muscle is carried down to preserve the frontalis branch of the facial nerve. The orbital rim is exposed until the frontal zygomatic suture is visualized. This step is key to allow downward retraction of the temporalis muscle and enhance the angle through a pretemporal corridor. Temporalis muscle is retracted long enough to expose the squamous portion of the temporalis bone. To avoid complications such as atrophy and CSF leak, it is key to remember the landmarks of the minipterional craniotomy. In such, the superior temporal line marks the superior limit of the craniotomy, ensuring the avoidance of entering the frontalis sinus. Sphenoid ridge is drilled flat and to expose on the lateral wall of the orbit at the level of the superior orbital fissure. At the lateral edge of the superior orbital fissure, it is possible to find the meningo-orbital band. This represents the continuation of the periosteal dural layer between the intracranial and interconal spaces. The meningo-orbital band is coagulated and divided, entering the virtual space between the periosteal and meningeal dural layers. Then, the peeling of the middle fossa is performed by combining sharp dissection techniques and gentle dynamic retraction of the dura propria using the suction tip. Peeling is performed from a medial to lateral direction so that this maneuver allows to expose the tumor over the lateral wall of the cavernous sinus, the tip of the anterior clinoid process, and the Meckel scape. At this point, we proceed with the decompression of the bony layer at the different points of compromise. First, the superior orbital fissure. Drilling is performed with 3 mm diamond drill that will help to achieve hemostasis of the infiltrated bone. Special care needs to be taken to avoid damage of the periorbita. The second step of the bony decompression entails the decompression of the optic canal and removal of the anterior clinoid process. A 2 mm diamond drill is needed to unroof the optic canal. Drilling is done under generous irrigation to avoid heat injury of the optic nerve. Finally, it is essential to undercut the optic strut to disconnect and gently remove the anterior clinoid process. At this point, tumor can be devascularized at its intracranial and intraorbital components. In this case, as in other spheno-orbital meningiomas, maxillary strut stands between the intracranial and intraorbital components. Removal of the maxillary strut is needed to achieve enhancement of the surgical view and its tumor resection. Once both compartments are communicated, periosteal dural layer is incised at the level of the orbit, and tumor capsule is dissected free from the periorbita. Dissection plane is followed backward using sharp techniques in the direction of the middle cranial fossa. This constitutes the preliminary steps for the extradural decompression of the cavernous sinus and the Meckel scape. Consequently, the exposures allow to visualize the intracranial extradural compartment. Extradural decompression progresses with the opening of the dural convexity. Intradural compartment is entered through 2 curvilinear incisions at the temporal and at the frontal dura. Both initial cuts are followed anteriorly to achieve dural decompression of the paracetal structures. First, temporal dura is incised using sharp microscissors. Incision is directed inferiorly in the direction of the temporal floor and the tentorial to meet with the prior dissection plane we draw from the orbit and Meckel scape. In parallel, extradural dissection allows progressive devascularization of the tumor using bipolar electrocautery. Once the intradural and extradural cuts are met inferiorly, trigeminal nerve can be fully decompressed, and tumor invading the Meckel's gate can be resected with minimal blood loss and adequate visualization of key neurovascular structures. Likewise, this medial dissection is carried down over the tentorium in the direction of the oculomotor triangle, which is the point of compromise of the third coronary nerve in this case. The second incision over the dura mater is performed over the frontal convexity. As before, this dural cut is extended anteriorly over the optic sheath to primarily decompress the optic nerve. This anterior cut is tangential to the falciform ligament and then is directed laterally over the external dural ring. The falciform ligament is open using a number 14 Joseph dissector. Incision over the optic sheath is continued laterally, and this third dural ring is sectioned to unlock the superior wall of the cavernous sinus and unfetter the internal carotid artery. This maneuver is essential to allow the lateral mobilization of the tumor from the lateral wall of the cavernous sinus. Now, the microscope is steered laterally to find the third coronary nerve at its entrance in the oculomotor triangle. Further vasal sister decompression is done to induce further brain relaxation. Now the tumor is fully devascularized and dissected free from the lateral wall of the cavernous sinus. Tumor debulking is carried down to ensure better visualization of key neurovascular structures. In this view, we are able to pinpoint under great magnification the third coronary nerve entering the superior compartment of the cavernous sinus, and the tumor remnant infiltrating the anterior petroclinoidal fold, and the portion of the tentorium medial to the pars trigeminalis. After identification of these structures, gross total resection can be safely achieved using SAR dissection techniques. At the end, the key of this intervention is to resolve the three coronary nerve compression at the oculomotor triangle. This triangle is composed of a thickening of the anterior tentorial edge, which is called the anterior fold of the petroclinoidal ligament, the posterior fold of the petroclinoidal ligament, and the interclinoidal ligament. The third cut communicating the intradural and extradural space is done over this triangle to free the third coronary nerve at its entrance into the superior compartment of the cavernous sinus. Section of the oculomotor triangle is done in a posterior to anterior direction, being careful with the lateral extension to avoid injury of the fourth coronary nerve that runs in the lateral wall of the cavernous sinus. Coagulation of the cavernous sinus is minimized, and bleeding from cavernous sinus is controlled with gentle pressure over gel foam patty and warm irrigation if needed. Reconstruction of the dural defect is done using inlay collagen matrix followed by onlay fasciolata, and then temporal bone is reattached using titanium screws and plates. Finally, the post-op scan shows gross total resection and decompression of the cavernous sinus, and at 6 weeks post-op, the patient fully recovered from her preoperative deficits and is still disease-free at 1 year follow-up.